Hi, good evening. Welcome to another episode of Let's Talk About Mental Health. I'm Nels Kloster. I'm an addiction psychiatrist. I work in Southern Vermont.
And my name is Robert Stack, and I'm a licensed mental health counselor and a licensed alcohol and drug counselor. Good evening. Welcome, folks. Want to again encourage people to send us any questions or comments, and that we really enjoy the comments and any questions you might have. And the whole purpose of the show was really to start a conversation, talk more about addiction, talk more about mental health, maybe reduce some of the stigma, get more information out there. I hope we've been serving that purpose. And one of the ways they can do it is to sort of contact us.
Right, we're on Facebook, facebook.com/Let's Talk VT, and it is cap sensitive. And if you message us, then that ensures privacy as you communicate with us.
And so one of the things that we thought we would do tonight, we did get an article, a comment about an article, and we want to talk more about that a little bit later. And the first thing I just wanted to mention is that this week in the New York Times Science section on Tuesday, they had an article about the increase in prescriptions for opiates for pregnant women. And mostly it was for women who were, and it was all Medicaid patients, I think, that they could track.
They took the numbers because they're easier to track.
Right. And they just talked about, mostly it was for back pain and discomfort. And, it's, I don't want to sound like a meanie, you know what I mean? I don't want like pregnant women to suffer, but I did find it a little bit alarming. And I'm not the only one. They were interviewing some folks and they were saying, boy, this is a big jump. I think it went from 20% up to 37 or something like that, the increase in the prescribing of opiates. And, I don't know what to make of it. I mean, I don't know enough about the treatment. I don't know much about treatment of, pregnant women. But it just was this worrisome thing to read about for me.
Yeah,
anyway.
Absolutely. And I mean, you forwarded it to me, and I read it as well. And as the doctors were talking about this as they interviewed, one very disturbing piece of this is that opiates are not a good medication. They were also talking about sort of intestinal distress, gastrointestinal distress too. And we know opiates are not a good treatment for that. And there's a lot of discussion too that they're really not the greatest medication for back pain either. And you've got these very sort of common struggles, common complaints that pregnant women will have. Great stress carrying that baby. Mm-hmm. The organs are smashed up, the back is overstressed, but opiate medications have not been considered a reasonable medication for that. So I think it really speaks to this sort of social attitude that, I'm uncomfortable, I shouldn't be uncomfortable. Fix it up. Give me a prescription.
And and it is. I just found it worrisome. I mean, it was just one article and it just talked about it, but it was kind of scary. And the other thing I just mentioned is that in our local paper there was an article about marijuana called Buzzkill.
In the comments.
Right.
The comments.
And this was a woman who was active in the National Alliance for the Mentally Ill, and she had some concerns. And it was interesting she said, she was talking about how for some kids they were at risk. That marijuana was, not only going to interfere with a lot of kids if they get access to it, and if you make it, well, I think when you decriminalize it, if you end up making it legal, it's going to be anytime you increase availability or access, you're going to increase usage. I don't care what, So I think it's a major concern. And she said, really, what struck me, and I'm sorry I'm being so inarticulate, but what struck me was she was worried about that percentage of kids that are really going to be adversely affected by marijuana. Mm-hmm. And that's always been my concern too, about, in some ways. I know lots of people who smoke pot and they went on to become doctors and lawyers and everybody else, But, my experience in a hospital was not to find that marijuana was a benign drug. And I also know people who smoke so much of it for so long, they're having a really hard time getting off it and stopping smoking. And, anybody who tells you that it's not addictive, I don't think that's true. I mean, I know people who wish they could stop smoking pot and find that they can't. And I'm also afraid that, there have been some cases where I think it's really interfered with young people development. And we should not just, I know, and I saw this thing on, yesterday was the big smokeout day. And so
Yeah,
they couldn't
420.
help. Yeah, and they couldn't help going to Colorado and saying, oh my God, it's legal there. And they interviewed somebody, and he was making these little e-cigarettes that had THC in it, the ones they have for nicotine. He's developing
so
that.
taking the active component of marijuana.
Yeah, and it was how much money he was making, and they were talking about how much tax dollars are going into the Colorado coffers, And yesterday there was on Channel 3 and Channel 13, the Burlington stations, they both would have pictures of the smoke out on the lawn of UVM and Redstone campus, and everybody smoking pot, getting stoned. And I don't know, there was a part of me that thought, well, I think there are some kids probably up there who are in their room studying. I bet there's some kids in the library who are studying. And as the kids who are smoking on the lawn, that's not just once a year they're smoking pot.
Yeah. I don't think there are any first-time smokers coming together for 420, or maybe they're being drawn into it for the first time. But and there's some, as you're saying something, there's some fairness issues involved with this too. On the one hand, people say, well, it's not fair if alcohol and tobacco are legal and marijuana is not, and to a degree, sure. I mean, nobody's going to, again, make illegal those products. Right. But we do realize that if you talk about addiction to marijuana, that the estimate is about 10% of people who smoke become addicted. Very similar to the percentages that people cite around alcohol, about people who are drinking becoming addicted to alcohol. So there's that idea of sort of balancing what is fairness as far as the drug policy goes. I mean, we've said it over and over again. I mean, do we really wanted to make it easier to acquire one more thing that is going to cause, problems socially? Because we know more people, people are pushing for legalization, but contrary to popular sort of belief, no other countries have legalized any drugs. They've decriminalized them, and they've coupled together the option for treatment with them. So this is really kind of a, not even bold, but sort of dangerous experiment maybe that's going on in Colorado and Washington, because we know when things are legal. We've seen this. We look at tobacco, we look at alcohol. There will be way more illness and way more cost to the healthcare system and socially as well. When you look at sort of job performance, for example, gross domestic product, these will be impacted to a much greater degree than we will garner revenues from people smoking. But a more important fairness issue for me is that essentially what we're saying here is that those who have some clout, those who are socially connected, have political power, they are in a way saying that, well, you know what, my desire to smoke marijuana without fear of penalty, that's more important than looking at the impact this is going to have on the disenfranchised and the disadvantaged. You're going to have young kids who are going to smoke. They're going to start earlier because it's available. They're going to be more vulnerable as a rule, and therefore we're going to see them do quite poorly, have bad results with employment, have bad results with psychiatric illness as well. And nobody's sort of sitting there saying, is this right to smoke without fear of punishment? Is that more valuable than even the potential impact on the vulnerable people in our population? Right. There needs to be somebody that's looking at a big picture on this.
And I just wonder, if you could, even if people said, well, we're going to make it really hard for kids to get pot. Okay, sure.
Right, yeah,
we work with booze, but good luck with that. Yeah. But do we really want all the adults getting high? I mean, do we really want to encourage or make it a way of, this is a revenue source. We're going to sell lots of pot. We're going to have a lot of people stoned. And I might have said this last week, and I don't mind saying it again, when they were interviewing Jerry Brown, the old hippie, governor of California. He said, well, how long can we be a great nation? How many people can be stoned and we still be a great nation? Something to that effect. Well, the idea, I think, is valid. I mean, it really is. I mean, what kind of country is this? What do we want our kids to be? What do we think is right? And I'm getting old and I'm getting conservative. I know. I mean, it's, and I was saying this the other day. I'm sort of, when I worked with addicts and alcoholics, I guess on some level I'm very liberal, but when I think about policy, I've become very conservative. I mean, I sort of worry about these things. I remember a client sort of complaining about the lack of certain treatments for him, and I wondered about it. I said, well, listen, why do you think you go to the head of the list for the healthcare dollar? You know what I mean? It was sort of like I wasn't quite clear about it. You know, like, well, he was saying, well, there's no slots or there's none of this and none of that, and I'm not sure about it. I mean, I don't mean to go off on that, but I'm really not sure about how to do this. And what's the right approach? What's the right approach? And I think the question that came in from one of our viewers, I think that's part of the issue. Yeah, so why don't we go ahead?
And I often get bogged. You get bogged down in the details sometimes.
Yeah.
Some people having opinions about legalization, decriminalization. Other people on a farther spectrum of more sorts of abstinence. I don't want to say puritanical points of view, and these are competing viewpoints. And whenever I get bogged down in that sort of thing, with work, daily, this little kind of worries and stresses. What saves me is to back up and take a big picture view and say, okay, why am I doing this? What's the point? And I get the feeling that we need to kind of do that as a country, as a society. Okay, what is the point? What do we want for outcomes here? What do we want to stand for, sort of the standard? What is our ideas of what is good health for the nation and even a larger population? And I'm getting to do this, sort of, as we've talked about, sort of, permissiveness is not the same thing as being progressive, as we talk about marijuana laws, but I just keep on seeing things. What is the prevailing attitude, and what does it mean that the prevailing attitude is going so much towards being more permissive? It's troublesome. And I want to put a plug in as we're talking about this, right? Brattleboro Area Prevention Coalition, a week from tomorrow on the April 29th at Brattleboro Union High School, along with Above the Influence, which is a student organization that is talking about you do not need to succumb to peer pressure on issues of drug use, sex, bullying, for example, are going to have what they call sort of World Cafe style discussion, and it really seems to be focused on, what are our attitudes? What do we want to stand for? And it's open to the public. They would like people to RSVP, but that's going to be there Tuesday, April 29th from 6 o'clock to 8 o'clock in the evening. So you and I are going to be there. I'm looking forward to see what kind of direction this takes, because I think this kind of it's a big picture discussion that needs to happen.
Yeah. And I just can't help but visualize where they're going to have these commercials. In Colorado, you can go ski and get high. And we have to keep up with Colorado. We got to keep up with the ski industry. And to me, it's like, are you sure you want everybody stoned going down that hill? I mean, is that really the?
And what your mother used to say? Look, if your friend jumped off the bridge, would you jump off the bridge too? There's logic to it.
I was joking with Roland when they were talking about putting a marijuana clinic up on Putney Road, and they're also at the same time they're talking about putting in all these roundabouts, taking out the lights and putting all the roundabouts. I thought, well, this could be interesting. I don't know. People going around like on MMT. I know that's not fair.
We're stereotyping.
Yeah, I know. I'm getting in trouble.
They won't all drive high, I'm sure.
Because I do want to say that people who have eye disease and that medically there is a reason. But even that's kind of cloudy. Dr. Senior wrote a letter about that, saying, what am I prescribing? What do you want me to prescribe? What is it? Who gets it? And I don't know. It just... I don't know.
Yeah, that's a front for legalization.
Yeah, I think so.
I think so too.
So why don't we talk about that?
Sure. Yeah.
The one that came in around the clinic.
One of our viewers wrote in and had noticed an article that appeared both in the Brattleboro Reformer and in the Vermont Digger, referring to the fact that the local methadone clinic here in Brattleboro, owned by a company called Habit Opco, was acquired by a group called CRC, and I don't even know what CRC stands for yet. The acquisition officially took place March 1st, and the thing that really sort of raises alarm bells is that the Bain Capital private equity firm that we all know from the Mitt Romney's run as the Republican candidate for president, is the company that owns CRC and now therefore owns Habit Opco as well. So it's raised, and as our viewer had written in, about what does that mean? Is this compatible with healthcare? And I think that is that's a huge question, absolutely huge question. There was also a follow-up article in the Reformer maybe a week after this one, generally pointing out the acquisition and some of the faults that have been found with CRC around delivering good care or adequate care. That by two economists, I think Elaine McCrate, who's with the UVM, and Eileen Applebaum, who's with the Center for Public Policy Research down in D.C., that there need to be concerns around this because there's a model by which private equity firms work. They acquire new companies with incurring a great deal of debt. They then, so in the case of CRC, Habit Opco, are then going to require payments in resources, payments regarding sort of advising and running the organizations. They also tend to then require the companies to pay dividends to Bain shareholders. And if a company is not profitable enough to pay dividends to their shareholders, then they're required to borrow money to pay dividends to Bain company shareholders. So as I'm glad the question came in because I was so concerned about this because I work there. And the idea of Bain Capital being involved sent a shiver down all of our spines. So I actually wrote to these two women, and they wrote back to me the next day and sort of explained all this to me. And I had to draw it out on a piece of paper with a graph with circles and lines going back and forth. But most of the arrows of the money are pointing back towards Bain Capital.
Right.
They'll do things like splitting up the acquired company into sort of an operating company and a property company. They'll have the operating company pay rent and other expenses to the property company. Then they will sell off the property company, and those sales will then go back to Bain Capital to sort of cover the losses. The acquired companies, they're faced with the need to increase their profitability. A couple of ways of doing this: you get more efficient, you sell your product more, or you decrease your costs, and that means paying crummy salaries to the people who work there. It means, in the case of, say, like methadone clinics, one of the criticisms of the CRC group was that in the past they had become more liberal around their giving medications to take home, which can lead to more bad outcomes, selling drugs, overdosing on drugs. There needs to be a very tight level of control over that if you're going to work towards public health. So there's a really scathing report in Bloomberg reports from a few years ago. And then Boston Globe printed an article maybe 2 weekends ago. And they were talking about this particularly, and what they did that was really illuminating is they put out the numbers in this Boston Globe article, so you realize what kind of money that we were talking about. Millions of dollars. So, they maybe put a third of their own money into that, and then 2/3 of the money they paid was also borrowed money that expects to be paid back. There's the idea that maybe, Habit Opco was acquired so that a profitable operation could then sort of smooth over some of the losses with the CRC group, and that CRC was probably not as profitable as Bain would have liked because they still own them after 7 years rather than selling them for a profit. Right. So, that's very concerning. And they have $49 million of interest payments on an annual basis.
Right. And then here's the dilemma for you, and I hope you...
Yeah.
Is that, in all that discussion of money, what is the best way to treat a long-term chronic illness of addiction?
Yeah.
It just doesn't come up. Our former Governor Dean, and this was after he was no longer running for office and no longer dealing with anybody.
So there might be a genuine opinion.
Yeah, that's right. Yeah. And he said, I think good health care and corporation profit are sort of incompatible. Now that's a paraphrase, but that's what he basically said. And you can't help but think that when you have a private corporation that is looking for profit and on a quarterly basis, and you're treating a chronic illness over a long period of time, is that really the best approach? And I think a lot of people sort of, well, how big a deal is this? If we give them the methadone, and that's fine, you know, give them methadone, what we're doing is it good for the general population. Right. Perhaps we're reducing property crime. You know, this is Nixon's war on crime all the way. Perhaps we're reducing them, recruiting new users, and we're giving them an opportunity to have a life. And I agree with that. I recommend patients on methadone. I don't have any problem with that. But I don't see the overall decision being a medical or a psychiatrist or a specialist, a psychiatrist making that decision. What's the appropriate level of treatment for this client at this time in their stage of their life, and what's the end goal?
Right.
You know, how are we going to deal with this later on, and all the other issues that go along with it. I mean, it just worries me. I mean, I don't know how else to say this, and I know that I've mentioned this before. I was involved with Richard Davis here in town, and we had around a single payer system, and everybody talks about the single payer system almost from the economics. How are we going to pay for it? How are we going to pay for it, and who are we going to pay? I wish somewhere along that conversation somebody would say, and while we're at it, why don't we do a better job of providing long-term care to people with chronic illnesses, and whether it's chronic illness like schizophrenia, what's the best way to treat schizophrenia? What is the best way over the lifetime of a schizophrenic, say from age 18, 19, 21 till 60, 50, whatever it might be, you're going to spend an awful lot of money providing services to that individual. What is the best way to provide services to that individual?
Yeah, and it's not just an economic question. It needs to be overlaid with sort of a social determination of what is important. In one way, this came to my mind. So in a way, if we talk about, for example, say methadone clinics and putting money there might be the idea that does this mean that we do then less dialysis for people with failing kidneys? Does this mean at some point that we say, well, to pay for all these younger people having this treatment, we no longer do so much open heart surgery? We think of less expensive sort of treatments, and we accept the idea that some people will do less well so other people can do better. And you can talk about this sort of quality life years as one sort of measurement of this sort of thing. But this really I really came to kind of see this in a different way when I was doing my undergraduate studies, and I was looking at the way science and politics intersect with each other. How do you make determinations in the political arena with scientific data? And around that time, electromagnetic fields were a huge concern. Do our cell phones cause brain cancer? Do people live under high tension power lines? Are they more prone to cancers, for example? And it could never come to a decision. The studies were just very unclear. Some countries made the decision, yes, this is valid research, and we're going to protect our citizens from this. Other countries were saying, no, it's not worth doing. But the one way this dilemma was framed for me is, okay, even if you believe the science that said electromagnetic fields could cause cancer, and they looked at children and they saw that maybe if you looked at children who didn't live under power lines, maybe 1 in 10,000 developed leukemia in this case. If you looked at children who did live under power lines, 4 out of 10,000 developed leukemia. So out of 10,000 children, those living under power line caused 3 more cases of leukemia out of 10,000 children. And if you looked at the cost of burying power lines, moving people's homes out from the vicinity of power lines, that cost a lot of money. If you took that much money and you built enough bridges over highways and streets, you would save 100 times more lives by doing that. So in a way, somebody has to make a social choice about what is worthwhile and what's important to treat and care for. But it also has to have a basis in science and economics. What's the best way for us to basically, taking a big picture view, right? What is the best thing for the health and safety of everybody?
So, I mean, in the Time magazine, everybody talks about the epidemic of heroin use. It's all over. It's no longer an urban area. It's no longer a seaport issue. It's everywhere, and it's growing. And the number of new people who doing heroin is going higher and higher. So at the same time, somebody says, well, that seems like a growth industry. What we're going to do is we have this epidemic of heroin addicts, so what we need to do is invest in treatment for heroin, and one of the treatments is methadone. And maybe that's good thinking. I don't know, whoever thought about it. But it's not. It's not good health care. It's not a good way to approach it. And I guess I'm really hoping that people sort of step back and take a look at that and say, I don't mind giving them methadone. I don't mind giving them Suboxone. But it doesn't have to be this is the only answer.
Right.
You have to come to our clinic. NA had this great slogan. NA used to say, the great lie is that once an opiate addict, always an opiate addict. And Narcotics Anonymous used to say that's not true. We have plenty of people who come to NA and get clean and sober and lead good quality lives, and they don't do opiates anymore. And I think that in some ways, there's people now who are doing heroin who have a lot of, they hear about Suboxone on the street, and they go, well, I want to get off heroin, I need to get on Suboxone. And that's okay. I mean, it's diversion, but, it's all right.
For a number of people.
And they try it, and they want to get better. But I think they're I think in a way our society is selling them short. And I think they're selling themselves short. They're really getting into a place, and I hope this is not true, where they believe that they can't live long, fruitful, productive lives without taking an opiate for the rest of their lives. And quite frankly, as a citizen, as a taxpayer, and as a therapist, I mean, I don't think that's the best answer. I mean, I really don't. I mean, honestly, if they need to be on medicine for the rest of their life, fine. But it's not the first option. It's not the second option. And there's appropriate times about, I think you have to have a long-term approach to chronic addiction and chronic illness with people who know what they're doing and have, I don't know, to have the patient's best interest at heart.
Where's the sense
I don't
that
know how else to say it.
The sense that I have some kind of power and responsibility for my own wellness, and that I can expect something that comes from my labor, which it elevates the level of expectation. And I mean, when I think about it, again, we're all about, let's find treatment, get treatment out there, get people in treatment right now. It's all at a level that's called, again, I've said this before, tertiary prevention. We're trying to stop you from dying or getting a lot sicker, but there's not a cradle-to-grave sort of perspective on what we're doing here. How do we prevent this in children? What is an appropriate approach for prevention? And a couple of sources I look at with around this, Michael Moore's movie Sicko, and there's a book by a journalist T.R. Reid called The Healing of America, looking at the way other countries deliver care here. And there is a larger picture around this. Insurance companies are not for-profit companies. So they're not based on a fee-for-service, which is the way that we make a whole lot more money here in the U.S. Insurance companies make a profit by withholding health care, whereas in other countries they're looking at preventative measures and they're rewarded based on the overall health of their patient cohort, their practice. If you meet certain indicators of good health, preventing illnesses from happening in the first place, earlier levels, primary, secondary prevention, stop the illness from happening, nip it in the bud, that's what we're missing here in the U.S.
They want us to wrap up, and we don't mean to turn this into politics, and I apologize. I apologize to the good workers in methadone clinics throughout the state of Vermont. I know you're there because you want to be helpful, but I think we need to take a look about how we provide that service.
No, absolutely. It's a bigger picture that's needed.
It is a good medicine. We want to use it, but I don't think it's a for-profit.
Oh, everybody in the industry would love to be part of prevention.
Right, or at least helping the ones that need it, but also more than just one thing.
Thank you.
Good night. That's my camera.
That would be my camera.
His, and this is our
camera. I've learned to work the camera. And when I notice at the corner of my eye, oh, that's my face on the camera, then I try to kind of work the camera a little bit more. Like I'm an expert.